Assalamu alaikum. All candidates are requested to be seated on the front lines. Assalamu alaikum. I'm Dr. Amara Kalim, fellow in the NeoColoquium.
ما لا إله إلا هو ملك المؤمن العزيز المتعال الله ما يشركون والله له الملك
international unit per ml. So that means that even vaccinated females can contract rubella if their immunity is not properly attained after vaccination. So we need to be able to quantify quantify and stratify the
चेक करें
vaccination
क्या
level,
कोई
immunity level
फ़ायदा
of
नहीं
a
हो रहा है
vaccinated
इससे
patient as well. If we are sure that she has had exposure to rubella, we need to be able to identify whether she has enough immunity to do so. Next is a patient who has contracted acute rubella. She will have IgG and IgM rising titer over a period of 2 to 4 weeks after her exposure. That is the definite diagnosis of rubella. And the gold standard, of course, is viral DNA secretion in the patient's secretion. That can be in respiratory droplets, in urine, in even in amniotic fluid. Okay, so this is how we diagnose rubella because IgG and IgM may be misleading in some cases. Next, after stratification, if a patient is exposed to a patient with rubella, how do we diagnose whether she has contracted rubella and whether she has passed rubella onto her baby? So we will repeat IgG and IgM investigations even if done at the local level because as I have already told you, even vaccinated individuals, however less frequent, they can acquire rubella as well. So we will repeat IgG and IgM after 2 to 4 weekly interval. Now, as you can see, if IgG is positive and IgM remains negative, then there is no risk to the patient and no risk to the baby as well. However, if both IgG and IgM are negative, that means that the patient can contract rubella, even if she hasn't contracted in this exposure. So we need to counsel the patient that she is at risk and she needs to be vaccinated after delivery. Here, I'd like to mention that in this Here I'd like to mention that even if a patient is inadvertently vaccinated during first trimester, as it is a live vaccine, there is theoretical risk, but no cases have been reported with congenital rubella syndrome if a patient is vaccinated accidentally during pregnancy. So you need to counsel the patient that she is not at risk, however, it is better delayed still after delivery. Thirdly, if a patient is unfortunate enough that her IgM is rising or IgM IgG titer rise over the next 2 to 4 weeks, then we indeed have a patient with acute rubella and she needs to be vaccinated as well. Next, the management of rubella. In an ideal world, universal screening for rubella should be done. Every single mother should be vaccinated before getting pregnant, and this will eliminate the possibility of congenital rubella syndrome. However, it is not so. So, if a patient advises a present to us before pregnancy, then we can counsel her to get vaccinated. It's just a single dose vaccination, repeated after 1 month for booster dose. Even if single dose is given, it's enough to acquire immunity in an immunocompetent individual, and
आपके यहाँ
congenital
से भी
rubella
आवाज़ आ रही
syndrome
है
can
इसको
be
माइक
avoided.
करो
If a patient
an immunocompetent individual are eventually eliminated, but it can still lead to fetal hydrops if anemia gets severe enough. So we have to go for a lookout for 8 to 12 weeks after acquisition of mother by this, after acquisition of this virus by the mother, and MCA Doppler will tell us for 8 to 12 weeks MCA Doppler, if it tells us that anemia is getting severe, we can opt for in utero transfusion. However, we need to tell the mother then that these changes will revert and there is no serious risk to the baby. However, after 20 weeks, there is still a risk of intrauterine demise if anemia gets severe and goes unnoticed. Last is toxoplasmosis. Toxoplasmosis, as we all know, it is transmitted by handling or ingesting raw meat or handling cat litter. It is mostly disease of the West, but as we don't have statistics mostly available, so toxoplasmosis may as well be undetected in our population as well. It poses minimal maternal risk in an immunocompetent individual, and up to 85% of the congenitally infected fetuses have subclinical manifestations, and most of them go unrecognized as well, but it can also lead to serious sequelae. Toxoplasmosis is transmitted trimester-wise. Its transmission to the fetus increases, and it can lead to intrauterine demise, hydrocephalus, CNS calcifications, which are a hallmark of this disease, and chorioretinal scar. How it is transmitted? If a mother is exposed, she can remain asymptomatic, so the diagnosis is dependent upon serology. If IgG is positive, IgM is negative, we don't need to do any further intervention. If they are both negative, then we just need to reassure the mother that she does not have the disease, but she is at risk, and if we are strongly suspecting exposure, we can repeat these after 4 weeks. But if IgM is positive or IgG is positive or negative, then we have to repeat IgM, as it is non-specific for toxoplasmosis. And even here, IgG avidity is helpful in diagnosis. If patient has low IgG avidity or IgM is rising, then we can confirm that it is indeed an acute infection. So if there is evidence of recent acute infection, this is a disease, fortunately, where treatment of the mother can reduce the drastic complications in fetus if caught early. So with a high index of suspicion, if we have detected the mother in time, we can start maternal antibiotic therapy with spiramycin. Once we have detected that mother has acute infection, we need to divide the fetus into low risk or high risk and treat the mother accordingly as well. So fetal risk assessment is, in first trimester, the vertical transmission is only 15%, in second trimester 44%, and third trimester 71%. Now, how do we diagnose that fetus indeed has an infection? So here again, we have non-invasive and invasive investigations. Once non-invasive investigation, like a detailed ultrasound, has picked up some soft tissue markers, we can go for invasive investigations for definite diagnosis of the baby. If fetus is indeed infected, then we can increase the maternal antibiotic therapy to include pyrimethazine and sulfadiazine. If the mother is still early in her pregnancy, we need to add folinic acid as well. However, if she is way past into second trimester, folinic acid doesn't need to be added. Now, how long will we give this antibiotic therapy? That varies across the globe, and we should follow the local guidelines for that. So if we have confirmed this infection, we are giving the mother therapy. We also need to do surveillance of the baby as well to detect that whether the baby is suffering from some serious sequelae or not. And this surveillance will not stop at birth. It will continue after birth. Neonatal assessment at birth is necessary to rule out the anomalies. And if IgG does not persist beyond 12 months of age, we can safely say that vertical transmission has not taken place. This concludes my session. Thank you all for listening.
Assalamu alaikum. My name is Dr. Farah Haroon, Associate Professor in Neonatology at University of Child Health Sciences, Lahore. Before we move on, I would like the session to be a little interactive. If any of the participants could tell me or share with me their experience diagnosing and managing congenital infections, what problems they face while they are diagnosing or managing congenital infections. Is it easy, or you have difficulties when you get a report of IgG or IgM? Can anyone share their experience, please? Koi bhi. Yes. Mic de dein, please.
Assalamualaikum. My name is Dr. Khadija and I'm from Punjab Rangers Teaching Hospital. We had a case of cytomegalovirus infection. Luckily, the child was diagnosed with it. So currently we are managing that patient with, the fits are controlled luckily, and he is on follow-up, and we had no issue regarding diagnosis of this CMV in mother through IgG and IgM levels. So
Okay, can you share what were the results of IgG or IgM?
they were raised in mother. I think IgG was 4 times raised actually.
And IgM was?
That I don't remember, but I just remember IgG.
Did you go for a PCR?
No, that was a serology, that indirect method.
Okay. So we are going to discuss today the importance of IgG, IgM and PCRs in various congenital infections, and hopefully we'll try to reach to a point where we know how to diagnose and manage these patients. Okay, we'll start with the congenital cytomegalovirus infection. Congenital cytomegalovirus, it belongs to the herpes virus family, and it affects 0.5 to 1% of live births in developed countries, and it is more in developing countries. It is one of the leading cause of non-genetic sensory neural hearing loss. The reason why it is important is even some CMV patients are asymptomatic, and we miss these patients, and later on we diagnose them that they have sensory neural hearing loss. So whenever we suspect or we have a baby, we should keep a high index of suspicion. If there are some points favoring CMV, to monitor these patients to prevent sensory neural hearing loss. Now, when to suspect that the baby can have congenital CMV infection? These symptoms are very common and overlapping in majority of congenital infections. The symptoms are same in more or less in all congenital infections, like we suspect a baby. When antenatally our gynecologist or obstetrician say that the baby is smallish, has intrauterine growth restriction with low birth weight. Sometimes they may tell us that there are intracranial calcifications, and when the baby is born, we see that the baby is IUGR, has microcephaly, there may be jaundice, hepatosplenomegaly, bruises and petechiae, blueberry muffin rash, CNS manifestations, like you mentioned, that the baby may have seizures. And eye examination, when we go for an eye examination, they may have cataract or chorioretinitis. So whenever we have a newborn baby, you will suspect that the baby might have CMV infection with all these features. Pointer nahi chal raha. Now, the risk of fetal transmission and its sequelae. Whenever a pregnant baby may have CMV infection, it could be primary, as Dr. Rizwana mentioned, it could be a primary infection or a reactivation infection or a secondary infection. Primary maternal CMV or non-primary CMV. Both of these will lead to fetal infection, but the risk is different. With a primary maternal CMV, the risk is 30 to 54%, and with non-primary, it is 1 to 3.5%. Whenever there is a primary CMV infection, the patient may be symptomatic or asymptomatic. Symptomatic are only 10%, whereas majority of them are asymptomatic. 90% are asymptomatic. Now, the sequelae are different with, of course, with symptomatic patients, the sequelae are 36 to 90%, and with asymptomatic patients, the sequelae are still there, 5 to 15%, and majority of them may have sensory neural hearing loss. So therefore, we have to keep an index of suspicion in CMV patients. Even if they are asymptomatic, we have to monitor them for deafness. Before we go on to the management of CMV, it is necessary that we divide these patients into mild, moderate, or severe, and then we can treat these patients, which patient need treatment and for how long. So, in a mild disease, the neonate may have only a few mild symptoms, 1 or 2 of these following, like petechiae, mild hepatomegaly or splenomegaly, biochemical abnormalities like thrombocytopenia, anemia, leukopenia, and mildly elevated LFTs. They may be small for gestational age and without microcephaly. The moderate symptoms include the symptoms persist for more than 2 weeks and have clinical presentation with 2 or more of these signs like petechiae, hepatosplenomegaly, and biochemical abnormalities. The severe disease includes CNS manifestations like seizures, microcephaly, CNS calcification, which is usually periventricular, chorioretinitis, white matter changes, hydrocephalus, and life-threatening multi-organ dysfunction, severe single-organ disease, and isolated sensory neural hearing loss is included in a severe disease. Now, what are we going to do when we suspect a patient with CMV? We have some routine tests which include complete blood count, which will show anemia, leukopenia, thrombocytopenia, elevated LFTs, conjugated hyperbilirubinemia, and when we go for a CSF analysis, we will see that there is mononuclear pleocytosis with the elevated proteins. The diagnostic tests include viral serology, IgM antibodies, which has a 20 to 70% specificity and sensitivity. CMV PCR in urine, saliva, and blood are the gold standard for diagnosing CMV. Urine PCR has a 92% sensitivity and 96% specificity. Eye examination is important for chorioretinitis, and cranial ultrasound MRI will show periventricular calcifications. So for diagnosing and confirmation of CMV, it is necessary that the patient has a positive IgM. IgM should be positive, and we should have a positive PCR. It is easy to get a PCR done we can get it done on saliva, urine, and other serous secretions. Now, which patients need to be treated? For a milder disease, we do not need any treatment. For moderate disease, we will consider treatment after discussion with an infectious disease specialist. The duration is a minimum of 6 weeks to 6 months. In severe disease, the patient has to be treated, and with CNS disease or isolated sensory neural hearing loss, 6 months or up to 1 year, we may be treated. Severe multi-organ or no CNS disease, a single organ disease, we need treatment for 6 weeks to 6 months. The current treatment, oral ganciclovir is currently the drug of choice, and intravenous ganciclovir should be used in babies who cannot tolerate oral medication. Normally in our setup, we usually have IV ganciclovir, so we use that, but oral is also available. The baby has to be, the dose for intravenous is 6 milligram per kg per dose of IV ganciclovir and 16 milligram per kg per dose of valganciclovir oral solution. The monitoring includes routine monitoring, that is complete blood count to see neutropenia, LFTs weekly for the first 4 weeks, then monthly for till completion of treatment, viral load at baseline, then 2 to 4 weekly on antiviral therapy. We have to monitor for drug toxicity and see the LFTs. Audiology assessment every 3 to 6 months for the first year, then every 6 months till 3 years, and yearly till 6 years. Developmental assessment at 1 year, eye examination at birth, and then yearly up to 5 years. This goes for severe disease and moderate disease. Now question arises whether mothers should feed if they have babies with CMV or the mother was CMV positive. For neonates who are more than 32 weeks gestation or more than 100 grams, babies should be given pasteurization of milk is important, freezing, or we can do ultraviolet radiation. For term babies, mothers can give their milk, but it is better to pasteurize. The prognosis is variable. A significant percentage of CMV infected newborns who have symptoms die, which is around 10 to 12%. Most of these who survive do have neurological problems like hearing loss, intellectual disability, and vision problems. 5 to 15% of newborns who are asymptomatic may develop neurological problems, but they are typically mild compared to problems developed by newborns who have symptoms. And the most important is hearing loss. So this is just a cartoonic presentation that most newborns with congenital infection CMV are asymptomatic, but 15% may develop sensory neural hearing loss. 10% of the congenitally infected newborns will have symptoms like chorioretinitis, hepatosplenomegaly, jaundice. For treatments, for neonates who are symptomatic, treatment with ganciclovir would protect them against hearing loss and developmental impairment. So the reason for treating CMV patients is to prevent neurological impairment and hearing loss. So it is important for diagnosing CMV, keep a high index of suspicion for babies who are IUGRs or have symptoms, and then treatment of these babies and follow-up. So next is congenital rubella syndrome. Background. Rubella virus is a single-stranded RNA virus belonging to toga virus transmitted through droplet infection, shed by respiratory secretions of respiratory infected person. It is the only, as Dr. Rizwana said, it is the only preventable disease among the torch infections. Congenital rubella syndrome occurs when the infection is in the early trimester, that is 8 to 10 weeks of gestation. Congenital rubella infection occurs when the baby's mothers acquire infection after 18 weeks of gestation. The classical triad of rubella, everyone is familiar with the classical triad: cataract, deafness, and congenital heart disease, usually a PDA. The babies may have, the babies are small IUGR. They have a rash, blueberry muffin rash, petechiae, hepatosplenomegaly, and jaundice. So the condition is overlapping with other torch infections. And the only one of the differentiating points is congenital heart defect, that is PDA. Management and follow-up of infants at risk of infection. Now, ensure clinical attendants are rubella vaccinated and have specific antibodies detected, and examine infant for evidence of congenital rubella syndrome. Investigate the infant. We can go for IgM antibody, PCR of urine and throat swab, and it should be noted that a negative PCR will not exclude infection. Culture urine and throat swab to a conjunctival swab length tissue, if available, may take several weeks. Now, at birth, if we are suspecting they have features of congenital rubella syndrome, we'll go for IgG antibodies, and if they are double the maternal IgG antibodies, we'll go for IgM antibody is positive and PCR is positive. If all three are positive, it means that the baby is symptomatic and is infected infant. If there were no clinical features of congenital rubella, but IgM was positive and PCR was positive, the baby is asymptomatic infected infant and risk of late onset disease or years after birth. And if the IgG is negative, IgM is negative, and PCR is negative, infant is probably not infected. So in that case, we will reassure breastfeeding is not contraindicated and confirm absence of infection by repeating the IgG titer at 9 months of age. If the baby was infected, there is no specific treatment. We cannot give any antiviral therapy. Breastfeeding is not contraindicated. We will monitor the baby for eye, cardiac, and hearing assessment. Regular assessments are indicated 3 to 6 monthly in the first few months and years of life to detect emergence of late abnormalities. Infants are infectious for at least 12 months after birth and are potentially infectious, so they have to be isolated. Ensure all hospital contacts and caregivers are rubella immune. The message in rubella infection is that we have, as Dr. Rizwana indicated, that we have to counsel teenager girls to get rubella vaccinated or in their childhood to be vaccinated twice at the recommended EPI schedule. I know the torch infections is a very heavy subject and sometimes a little boring, although I have made it a little simpler. So if anyone wants to ask one question, I can give a break. कोई नहीं? जी.
Basically, I have 3 questions.
I think okay.
अच्छा मैडम, यूजुअली न्यूबॉर्न्स में लिवर पैल्पेबल होता है, सो व्हेन डू वी सस्पेक्ट के ये पैथोलॉजिकली लिवर इनलार्ज है? नंबर 1. नंबर 2, सेप्सिस के अंदर बेबीज आमतौर पे हमारे पास सेप्सिस के साथ आते हैं, उसमें थ्रोम्बोसाइटोपिनिया भी होता है, अनीमिया भी होता है, तो हम कब सस्पेक्ट करेंगे कि ये माइट बी ड्यू टू द टॉर्च इन्फेक्शंस? नंबर 3, वंस द बेबी डिस्चार्ज, हमारे पास दोबारा किन कंप्लेंट्स के साथ आ सकता है जिसमें हम सस्पेक्ट करेंगे कि द बेबी माइट हैव टॉर्च इन्फेक्शन?
ओके सर, शुड आई आंसर और सर आप हाईलाइट करेंगे? ओके, योर फर्स्ट क्वेश्चन वाज that baby might have hepatomegaly, why we are suspecting torch, right?
मैम न्यूबॉर्न्स में लिवर
Hepatomegaly
होती है, तो हम कब सस्पेक्ट करेंगे कि दिस माइट बी पैथोलॉजिकल?
We usually suspect torch. I will repeat again. We get an antenatal call from a gynae department that the baby is intrauterine growth restricted, that is a smallish baby. They may see calcifications in an ultrasound. Or when the baby comes to us in our neonatal unit, we see a very smallish baby, maybe a term baby with a 2 kilo weight or 1.5 kg weight, who has other symptoms also, like a small head, microcephaly, and jaundice, hepatosplenomegaly. petechiae. We haven't done any tests yet. So it strikes to our mind that the baby might have torch. So these are the indicators that the baby might have torch, which includes quite a number of torch infections. And if it was missed and the baby came back later on, as it happens in the pediatric unit, the baby will not gain weight, will have conjugated hyperbilirubinemia, and will have hepatosplenomegaly, and eye symptoms or a murmur in heart, which again will indicate that the baby might have a torch infection, which was missed initially. Is it clear?
एक और सॉरी, हमारे पास न्यूबॉर्न्स जो आते हैं वो सेप्सिस के साथ आते हैं आमतौर पे, और उनके अंदर अनीमिया भी होता है, थ्रोम्बोसाइटोपिनिया भी होता है, तो उस सिनेरियो में हम टॉर्च कब सस्पेक्ट करेंगे अगर कोई और प्रेजेंटेशन नहीं आ रही, सिर्फ लैब्स में थ्रोम्बोसाइटोपिनिया है, अनीमिया है?
Those babies are appropriate for their gestational age. Their weight is appropriate for their gestational age. They don't have a small head, but they have other features like anemia and thrombocytopenia. So I think, okay. Now we move on to toxoplasmosis. Toxoplasmosis is a protozoan parasite which usually infects animals and humans. It causes serious disease in immunocompromised and causes congenital infection. The asexual cycle of toxoplasma occurs in human and animals. The reason for transmission is eating undercooked meat or unhygienic conditions. These are a source of infection. The available literature says that 25.8% of human beings are infected by toxoplasma in Pakistan. The prevalence is 20.6% in males and 26.82% in females. The rate of infection increases with age. The infectivity, by the time we reach adulthood, everyone might have acquired toxoplasma. It was found that in humans at age range 40 to 60 years, the rate of infection increases with age, as high as 37.3%. Now, how we acquire toxoplasma? It is a little difficult, so we start with the cat, that is A. The cat passes the unsporulated oocyst, which becomes sporulated in the soil. These sporulated cysts are ingested by the cattle, that is the lambs or goats, and they form tissue cysts. Or from the soil, we eat unwashed vegetables or unboiled water or dirty water which is ingested by us. So we acquire it, the sporulated oocysts are acquired through the cattle that in the form of tissue cysts or the unwashed vegetables. Once we have acquired this, the techizoids are acquired and they cause severe fetal infection. We can also acquire them by blood transfusion. The baby presents with a number of clinical features, and most severe of this is the chorioretinitis, which is 85 to 92%. Intracranial calcifications, abnormal CSF findings, which include pleocytosis and elevated proteins, hydrocephalus, jaundice, and the rest are the same, which include thrombocytopenia, anemia, hepatosplenomegaly, rare seizures, microcephaly, and microphthalmia. But the severest is chorioretinitis. Now, diagnosis may be suspected on maternal serology, and it relies on clinical and lab findings at birth. How we are going to diagnose? By doing serology, IgG, IgA, and IgM, toxoplasma, PCR on CSF, blood, urine, vitreous fluid, and cord blood. Eye evaluation for chorioretinitis, neurological evaluation by lumbar puncture, and neuroimaging. The calcifications are diffuse. They are diffuse in toxoplasmosis and periventricular in CMV, which is one of the differentiating points. Hearing evaluation for hearing loss. Some routine tests which are the same individuals show anemia, thrombocytopenia. We'll do a baseline uracreatinin, immunoglobulin levels, and testing for other torch infections, and placental examination at the time of birth. Now, a little complex algorithm. Congenital toxoplasmosis infection on antenatal testing that was positive for Toxoplasma gondii, PCR, or amniotic fluid. Or maternal infection, there was maternal infection which was treated or untreated, or fetal infection is unknown, negative with negative Toxoplasma gondii PCR. We'll investigate the baby for IgM, IgA antibodies, maternal and infant IgG, and go for placental histology and PCR, and CSF Toxoplasma gondii PCR. If IgM or IgA is positive and PCR is also positive, or infant's IgG is more than mother's, we'll go for a full clinical examination, including eye, hearing assessment, an MRI or CT scan, or ultrasound. If it is abnormal, this means that the baby has symptomatic congenital toxoplasmosis, and we have to treat this patient. However, if the imaging was normal, it means that the baby has asymptomatic congenital toxoplasmosis, and even this baby has to be treated. If fetal infant investigations and placental examination was normal, we'll go for a full clinical examination. If this was normal, it could be normal or abnormal. If it is abnormal, we'll seek expert advice and commence treatment if the signs are consistent with congenital toxoplasmosis, and monitor the serology. We'll repeat IgM at 3 months and IgG at 12 months, 6 and 12 months. If positive IgG at 12 months, we'll repeat IgG beyond 18 months. If IgG persists, if IgM or A are positive at 3 months, it means that the baby has asymptomatic congenital toxoplasmosis. If the IgG persists for more than 12 months, it is the same that the baby has asymptomatic congenital toxoplasmosis, and we'll treat these patients. If the IgG remains negative, then no treatment is required. The treatment is usually with pyrimethamine and sulfadiazine, including folinic acid, for more than 12 months of age after diagnosis, because there is a risk of reactivation, which can cause serious disease like worsening of chorioretinitis, so the baby has to be monitored and treated. So serial monitoring of the serology cultures are important in toxoplasmosis. We will also monitor for hearing loss, vision, and neural development outcome. Varicella infection. Congenital varicella syndrome. The most cases occur if mother is infected between 8 to 20 weeks of gestation. This is congenital varicella syndrome. It is a severe form of infection leading to high mortality and morbidity. However, the risk is low, which is 2%. It is less than 1% if it occurs before 13 weeks. The characteristic findings are IUGR, cicatrice, skin lesions, ocular defects, cataract, chorioretinitis, microphthalmia, limb hyperplasia, CNS abnormalities like cortical atrophy, seizures, and intellect disability. Usually these patients do not survive. Though we have the patients we usually encounter are those where the mother is infected with varicella, or baby come in contacts with an infected person. If the index case is the mother may have chickenpox or herpes zoster. We have to see when she got the infection. Was the onset of maternal rash in the period from 7 days before to 7 days after delivery? If yes, give varicella zoster immunoglobulin. So immunoglobulin is given to prevent chickenpox infection in the neonate. 250 units IM. If it was not between 7 days before and 7 days after onset of maternal rash, VZIG is not required. If the onset of maternal rash was 7 days after delivery, or the baby is preterm, if it was not preterm, VZIG is not required. Now, if the indicase is not the mother, but there was a significant contact. If the contact was not significant, VZIG is not required. If the contact was significant, was contact within the first 7 days of life, that is the initial first week. If it was within the first 7 days of life, yes, infant born, or the infant was born less than 28 weeks or less than 1 kg, we will give VZIG. If the infant was more than 28 weeks of gestation and the weight was more than 1 kg, and there was a positive maternal history or an unknown status, check with maternal varicella zoster serology. If it is negative, give VZIG, and if it is positive, VZIG is not required. With positive maternal history, VZIG is also not required because the baby has got antibodies. Now, management. Infant of women with peripartum varicella zoster infection, VZIG, we have already discussed when to give VZIG. Prophylactic acyclovir should only be considered for infants whose mother developed varicella 4 days before, 2 days after delivery, because they are at the highest risk of fatal outcome despite VZIG. Mother and baby should be isolated and nursed in be encouraged. High dose acyclovir 10 mg per kg per dose 8 hourly for suspected neonatal chickenpox is given. In neonatal varicella, we treat varicella infection. Mortality and morbidity is due to pneumonia, encephalitis, hepatitis, and sometimes hematological abnormalities. This is the last topic I'll discuss, neonatal herpes. Has anyone come across neonatal herpes? No? Okay. We have seen a few patients in our unit, so we have to keep a high index of suspicion, otherwise we'll also miss neonatal herpes. So asymptomatic infant with low risk of neonatal herpes simplex disease is when mother may have recurrent genital infection or a primary genital infection or systemic infection, seroconverted well prior to delivery with or without genital lesions at delivery. Transmission is rare in this setting, and most experts follow infants for clinical disease and educate family about signs of infection in the baby. However, some experts may take swabs, eye, throat, umbilicus, and rectum, and blood for herpes simplex virus, PCR. So PCR is also required for confirmation of herpes simplex infection also. Newborn usually develop symptoms of clinical disease while monitored or swab growth detected usually later. Lab confirmed infection. Sometimes newborns develop signs and symptoms of herpes simplex disease, which include usually they may not have these symptoms at the time of birth, but they may present with symptoms around 7 days of life or the second week of life, and they present with initially a vesicular lesion or atypical pustular lesion, which later becomes bullous. Seizures, unexplained sepsis. They have thrombocytopenia, leukopenia, and these usually present with a pure septic picture, and we usually miss herpes infection even though they have vesicles. They may have low platelets, elevated LFTs, DIC, respiratory symptoms like pneumonia, and corneal ulcers or keratitis. They have eye discharge. So these patients are usually missed. I have not gone into the details of the types of herpes, classification of the herpes infection in neonates, which is skin, eye, mouth, CNS disease, and disseminated disease. The neonates with disseminated disease usually have those symptoms of hematological abnormalities and LFTs, abnormal LFTs. Asymptomatic infants with high risk of neonatal herpes disease are mothers with primary genital herpes or systemic infection close to the delivery, and when the baby was delivered by SVD, they are likely to acquire herpes simplex infection. So what are we going to do? We'll go for CSF analysis. Viral cultures in this case are very important. Herpes simplex PCR is important. Blood count, which will show neutropenia, thrombocytopenia, elevated LFTs may be there. Herpes simplex virus PCR in blood, and surface swabs of eye, throat, umbilicus, and the skin vesicles may show positive PCR. So it is very important to go for PCR of the skin lesions. And we will commence for acyclovir immediately from birth when we have a suspect herpes simplex disease, and the duration will depend on the surface cultures and CSF results. The treatment of choice is acyclovir, which is in a higher dose, 20 milligram per kg per dose, IV 3 times daily. In an infusion form, duration depends whether it is skin, eye, mouth disease, disseminated disease, or CSF disease. With skin, eye, mouth, the duration is shorter. With disseminated, it is for a longer duration, that is 21 days. For high-risk groups, or when there is, for encephalitis and DIC, it is 21 days. Preemptive therapy, high-risk asymptomatic infants without lab confirmed, it is 10 days of treatment. Herpes simplex CSF PCR, if it is positive, we will repeat LP and herpes simplex PCR towards end of treatment to confirm viral clearance. If it remains positive, extended treatment may be required, or we will go for an alternate viral agent, foscarnet. All cases of lab-confirmed infection, survival should be monitored for recurrences like eye disease, hearing impairment, and neurological sequelae. Acyclovir prophylaxis is sometimes given, which we have given in some of our patients, when they have CNS disease, disseminated infection. It is recommended for all infants with herpes simplex encephalitis, oral acyclovir 20 milligram per kg per dose 3 times daily for 6 months to improve CNS outcomes and also prevent the eye abnormalities. Skin and eye, mouth, or disseminated infection without CNS involvement, some experts may use oral acyclovir to suppress troublesome cutaneous recurrences after skin, eye, mouth disease, or to reduce early reactivation after all forms of disease in any infant or in preterm infants, but not routinely recommended. Okay, thank you.
Bismillahirrahmanirrahim. Assalamu alaikum. ये पॉइंटर नहीं चल रहा, नहीं चल रहा, ये नहीं है मेरी। Infection prevention for babies protection, because we know prevention is better than cure. So these points, the following points we must have a look on the following points to counsel pregnant women. First of all, seek CDC's advice for couples who are planning pregnancy. Wash hands with soap and water after using bathroom, touching raw meat, raw eggs or unwashed vegetables, after changing diapers and before preparing food and eatables. Reduce saliva and urine contact of baby and young children, and do not share your food and utensils. Avoid to use unpasteurized milk and food because it may contain an harmful bacteria. Do not touch or change dirty cat litter. If you must have to do it by yourself, be sure to wear gloves and wash your hands afterwards. Stay away from animal, rodents and their droppings. If you have a pet animal, have someone else to care for it until your baby have arrived. Isolation of babies with positive PCR or any active infection such as cytomegalovirus, chickenpox and herpes. Talk to your healthcare provider about vaccinations such as MMR and MRV. Thank you.
Assalamu alaikum. I am Dr. Aisha, neonatal fellow, Fatima Memorial Hospital. I am going to talk about congenital dengue infection. Congenital dengue infection can result in neurological abnormalities, which include anencephaly, microcephaly, encephalocele, and hydrocephalus. There is 5% risk of stillbirth, 20% risk of preterm birth, and 5% risk of low birth weight. During the perinatal period, intrauterine transmission is greatest when a pregnant woman delivers at the peak of dengue viremia, and there is insufficient protective maternal anti-dengue IgG to transfer to the fetus. The duration of viremia and the febrile phase lasts longer in newborns experiencing primary infection. Average time between maternal fever and neonatal symptoms was 7 days, with a range of 5 to 13 days. Pregnant female can pass dengue virus to fetus if she develops fever from 10 days before delivery to 10 hours after delivery. Mode of delivery does not affect the rate of transmission, and breastfeeding may contribute to transmission. Clinical presentation include fever and thrombocytopenia that may appear 1 to 11 days after birth with an average of 4 days and last for 1 to 5 days. Other features include hepatomegaly, hemorrhage, effusion and rash. Rarely, dengue shock syndrome can occur with severe bleeding requiring platelets and red blood cell transfusions. The mortality rate for severe dengue fever is 0.8 to 2.5%. Diagnosis can be made by identification of the dengue virus in cord blood samples. The positive dengue serology within the first week of life, together with confirmed maternal dengue infection during pregnancy, supports the diagnosis of vertical transmission. IgM can be detected as early as 4 days after the onset of illness. The diagnosis is, however, confirmed by IgM seroconversion, with a fourfold a greater rise in antibody titers is diagnostic of acute dengue infection. Next, I'm going to talk about congenital syphilis. Congenital syphilis is caused by Treponema pallidum, which is a thin, motile, and fastidious organism that survives only briefly outside host, and it cannot be cultivated successfully on artificial media. Transmission occurs either via direct sexual contact with ulcerative lesions of skin or mucous membranes, or either transplacentally, which typically occurs during second half of pregnancy, but it can occur as early as 6 weeks of gestation. And pregnant mothers with primary or secondary syphilis are more likely to transmit the disease than those with latent disease. Transplacental transmission rate is almost 60 to 100%, especially with early stage of maternal syphilis. Congenital syphilis does not have a primary stage. The placenta of neonate with congenital syphilis is large and edematous. Other features are choriamnitis, punicitis, and vellitis. And dark field microscopy for treponemes is diagnostic. In the fetus, initially there is placental involvement and hepatic dysfunction, followed by amniotic fluid infection, hematological abnormalities, ascites and hydrops, and stillbirth and neonatal death can occur. The risk of intrauterine death is almost 25%, and if untreated, the risk of perinatal mortality is almost 25 to 30%. Postnatally, the congenital syphilis is classified into early symptomatic presentation, in which clinical symptoms appear within the first 2 years of life, and late symptomatic presentation that presents after the 2 years of life. In early symptomatic presentation, mucocutaneous involvement occurs in almost 30 to 60% of the affected infants, and these include thick or bloody nasal discharge and small blisters around palms, soles, nose, and anus which desquamate. Skeletal lesions occurs in almost 60 to 70% of the affected infants, and these include osteochondritis and periostitis. Other manifestations are neurosyphilis, hepatosplenomegaly. Labs shows laboratory diagnosis include CBC, showing direct Coombs positive anemia, thrombocytopenia, and high proteins in cells in CSF positive VDRL, extra long bones and joints, and raised LFTs. Now these are the desquamating blisters, multiple blisters shown in the neonate. These are the manifestations of late congenital syphilis. These are the showing notch incisors known as Hutchison teeth, interstitial keratitis, and copper-colored rash on the palms, on the soles. Diagnosis is made by a direct visualization of spirochetes using dark field microscopy in tissues from placenta or umbilicus or exudates from lesion. Serological tests for syphilis can be classified into non-treponemal tests, which include VDRL, rapid plasma reagent, and automated reagent test. Treponemal tests include treponema pallidum immobilization, fluorescent treponemal antibody absorption test, and microheme agglutination assay for antibodies to treponema pallidum. Assessment involves to identify maternal risk factors, multiple partners, drug use, no prenatal care, and unstable housing or homelessness. And all the pregnant females should be routinely screened with a non-treponemal test at first prenatal visit and at 28 weeks of gestation, and at delivery in the high prevalence areas. And if these tests are suggested, then mother should be adequately treated with 3 doses of benzathine penicillin along with neonatal and later follow-up. Now talking about different treatment scenarios. If the mother had syphilis before pregnancy and she was adequately treated and her titers remained low and stable before, during pregnancy, and at delivery, then a complete physical examination should be performed in the neonate along with non-treponemal titers. And if the physical examination is normal and non-treponemal titers are less than 4 times maternal titers, then no evaluation and treatment is required. If the mother had syphilis during pregnancy and she was adequately treated, appropriate for the stage of infection, and treatment was administered for more than 4 weeks before delivery, and mother had no evidence of reinfection relapse, and neonatal non-treponemal titers are less than 4 times maternal titers, then it is recommended to give benzathine penicillin G 50,000 units per kg per dose intramuscular in a single dose. If the mother had syphilis during pregnancy but she was not adequately treated, or there was no documentation of treatment, or she was treated with erythromycin or other non-penicillin regime, or she received treatment less than 4 weeks before delivery, then even if her neonatal non-treponemal titers are less than 4 times maternal titers, a complete neonatal workup should be done in the form of CBC, CRP, LFTs, long bone X-ray, CSF, VDRL, hearing, and eye assessment. A neonate should be treated with aqueous crystalline penicillin G or procaine penicillin for total 10 days. Dose is 50,000 units per kg per dose. Now, if the neonate had abnormal physical examination and or serum quantitative non-treponemal titers are more than 4 times maternal titer, plus proven dark field microscopy of placenta or umbilicus, or positive fluorescent treponemal antibody absorption test, then again neonatal workup should be done with, in the form of CBC, CRP, LFTs, long bone X-ray, CSF, VDRL, hearing, and eye assessment, and he should be treated with aqueous crystalline penicillin G or procaine penicillin for total 10 days. Now, non-treponemal tests are simple, cheap, quantitative tests. They're used for screening. They're sensitive but not specific. That measures antibodies directed against lipoidal antigen from treponema pallidum. These antibodies will have 4 to 8 weeks following infection, and that these must be confirmed by treponemal test. And in neonates, titers must be 4 times the maternal titer. False negative results occur in early primary syphilis, latent acquired syphilis, late congenital syphilis, and prozoon phenomena. And false positive results occur in viral infections, lymphoma, TB, malaria, endocarditis, and connective tissue diseases. Treponema tests are used to confirm positive non-treponema tests. They remain positive for life. The results do not correlate with disease activity. These tests are not quantified, and false positive results occur in other spirochetal diseases, for example, yaws, penta, leptospirosis, rat bite fever, relapsing fever, and Lyme disease. Next, I'm going to talk about congenital parvovirus infection. Parvovirus P19 is a single-stranded DNA virus that was discovered accidentally in 1975 during routine hepatitis B infection screening. Transmission mostly occurs in late winter and spring, with respiratory route being the commonest one with 50 to 60% transmission rate. Other routes of transmission are blood products and nosocomial. Now, what are the clinical symptoms in mother? Non-specific febrile illness, erythema infectiosum, arthropathy, anemia, or aplastic crisis. Talking about seroconversion, parvovirus P19 specific IgM antibodies in the serum appear in the serum in the second week. In the third week, specific IgG antibodies appear, and the rash of erythema infectiosum and arthropathy develop. Rash of erythema infectiosum signifies that virus can no longer be transmitted. In utero, parvovirus P19 infection is associated with fetal loss. The risk is 1 to 2%, and non-immune hydrophobia with 2 to 10% risk of fetal death. At birth, parvovirus P19 infection can cause hydrophobia with severe anemia and high output cardiac failure. Other clinical features could be rash, anemia, hepatomegaly, cardiomegaly, and rarely thrombocytopenia and myocarditis. Parvovirus P19 infection can be diagnosed with positive parvovirus P19 specific IgM antibodies, significant rise in parvovirus P19 specific IgG titers, and PCR for B19 DNA in amniotic fluid or neonatal serum or bone marrow. Management includes intrauterine fetal blood transfusions and neonatal transfusions to prevent congestive heart failure, intravenous immunoglobulins to treat chronic anemia from parvovirus P19 infection, and intrauterine B19 hyperimmune serum. Routine screening is not needed during pregnancy unless erythema infectiosum is present, there is hydrophobia, or there is known exposure to parvovirus P19 infection. Thank you.
Bismillahirrahmanirrahim. First of all, I would like to thank Professor Farah Haroon and his team for inviting me for this talk. Since we are running short of time, I would be very brief in discussing two topics of congenital tuberculosis and congenital malaria for the next, hopefully, less than 20 minutes. As you know, these diseases are not uncommon, but we usually don't think of these diseases commonly in our differential diagnosis, because both of these diseases present with non-specific signs and symptoms, and both of diseases should be included in differential diagnosis of septicemia, where the epidemiological link has been found. Not in every case of septicemia, but in all those cases of septicemia where we can find the epidemiological link, because in most of the infectious diseases we can find the epilink in these diseases. So we usually face the difficulty in confirming the diagnosis of these diseases, and reports in literature are also not so common. If we go on to the pathophysiology of congenital tuberculosis, there is interplay between the maternal, placental, and fetal liver factors. If there is tuberculous basilemia, dissemination of infection in endometrial or genital tract, that can lead to placental tubercle rupture into the fetal circulation, and the fetal circulation directly goes into the liver. Primary focus, unlike the adult population where the primary focus develops in the lungs, in neonatal or perinatal tuberculosis, or we can safely say that in cases of congenital tuberculosis, the primary focus is in the liver with involvement of periportal lymph nodes. Then tuberculous bacilli can infect the lungs. When there is tuberculous basilemia, then there is hematogenous subtype or aspiration or ingestion of the tubercle, and if there is hematogenous subtype, the focus would be in the liver most likely, and if there is aspiration, the focus would be in the lungs, and if there is ingestion, the focus would be in the gastrointestinal tract. Now, if we talk the diagnostic criteria, in 1935, there was initially diagnostic criteria were made, which was based on isolation of Mycobacterium tuberculosis from the infant and demonstration of primary complex in the liver with the absence of any contact with the case of tuberculosis after birth to differentiate from the acquired tuberculosis from the congenital tuberculosis. Then this criteria in early 90s was modified by Cantwell, and this is the modified criteria which also emphasizes the isolation of the tuberculous bacilli or tuberculous hepatic complex and caseating hepatic granuloma, with the exclusion of possibility of postnatal transmission by investigation of contact, including hospital staff. Age of presentation varies. Usually it may be first day or 84 days, but this is the time period which is reported in the literature, and cases are reported between these time period. Median age is 24 days of life, but we can expect this at any day if the history of contact is suggested. It can present with any signs of tuberculosis, any sign of septicemia, any presentation in the form of hepatomegaly, splenomegaly, abdominal distension, lymphadenopathy, lethargy, or in case of disseminated infections. What we have to do, we have to assess the maternal risk factors for tuberculosis. This is the most important thing, that we should differentiate that this is isolated septicemia, or we should consider the diagnosis of congenital tuberculosis in this kid. So if the placenta is available, the placental morphological and histological examination should be done for the culture of tuberculous bacilli, and particularly in those cases, gyne-obs colleagues should be alert that if the mother presents with inexplicable bronchitis, pneumonia, meningeal disease, or endometritis, or unusual uterine bleeding, the workup for tuberculosis or at least placental examination should be advised. And if the placenta is not available for examination and we would have to go for the maternal examination, then uterine dilatation and curettage should be considered, because endometrial culture often use positive results in this case. Now it is recommended that in cases of tuberculosis, HIV testing should be done to see the concomitant HIV infection as well. If we talk about the neonatal samples, all the samples which we can advise beyond the neonatal age, we can advise for these neonates, rather bronchoalveolar lavage, whether it is gastric aspirate, tracheal aspirate, swabs, discharge, fluid, or CSF, whatever the clinical presentation of the baby is, and we can do for the smear, and we can do for the gene expert or other nucleic acid amplification test in these samples. Ancillary test would be chest X-ray, which may give the finding or may not give the finding, like the infiltrates, lobar patches, and the CT thorax may help in cases of finding with scattered infiltrates, bronchopneumonia, consolidation, or periportal hypodensities. Tubercle skin test is usually negative in the kids, so usually not recommended. Interferon gamma release assays have lower sensitivity, so literature is almost silent, or rather controversial role that whether we should advise or not. If we talk about the treatment of congenital tuberculosis, the treatment now is the same as for the kids beyond congenital tuberculosis. This is RIPE, this is rifampicin, INH, PZA, and ethambutol. And if there is some absolute contraindication of ethambutol, we can use the aminoglycoside as well, but it is the second option now. And if we have the disseminated disease or meningitis is confirmed, corticosteroids can be added in these cases. Now the next we come across the 3 or 4 common scenarios when the mother is having the disease or infection, and what should be done to the neonate. Number 1 extreme scenario is that the mother is asymptomatic and his IGRA or TST is positive while his normal chest radiograph. The mother should be taken as a case of tuberculous bacterial infection. Now, the previously term was used at latent tuberculous bacterial infection. Now, the LTBI term has been replaced by tuberculous infection. You can say the TBI or TI. Mother is asymptomatic, no separation is required. Mother should be instituted with prophylaxis therapy as recommended, and a newborn doesn't need any special evaluation for the therapy. Yes, in every case, household screening should be advised. Breastfeeding should be continued, and the next other extreme scenario is that mother is having clinical signs and symptoms, abnormal chest X-ray or abnormal tuberculous skin test. Now, this is the case that the mother is having tuberculous disease. This mother is not having the tuberculous infection. This is the case of tuberculous disease. Mother should be isolated, kids should be isolated for the time being. Both should be investigated for the evidence of disease, or if the mother has been already diagnosed, just start the mother with the treatment and continue evaluation of the kid. Again, with this time period, when 2 weeks of treatment of either side have been completed, usually it is assumed that there is no contagiousity, and now after 2 weeks of completion of treatment and with reassurance of adherence of infection control measures, the mother and child separation is no longer required. Now we are treating the mother. Mother is being treated, 2 weeks have been completed. The other scenario comes that the baby is proved to be congenital tuberculosis. Shift to the baby to the treatment algorithm, continue with the mother-child bonding, continue with the breastfeeding. The other scenario is that you have evaluated the baby and baby is not been proved to the case of tuberculous disease. Now, baby is would be treated as a contact case and would be given the prophylactic therapy, and after 3 to 4 months, TST would be instituted, and if the TST is negative, discontinue the preventive therapy. If TST is positive, then continue the preventive therapy and reassess the baby for TB disease after 4 or 5 months, mean total of 9 months of prophylactic therapy. These are two extreme scenarios. Now, in between scenario is that mother is asymptomatic and has IGRA positive or TST positive and chest X-ray is symptomatic. Now, in this case, we have to reevaluate that whether this abnormal chest X-ray is due to tuberculosis or due to any other cause other than tuberculosis. So, if this is due to tuberculosis, then obviously we will go to the stem previously, that mother would be treated and usually no isolation required in this case because mother is asymptomatic. And if the mother have X-ray other than cause other than tuberculosis, then we will treat the other cause and we will treat the mother as a case of tuberculous infection or previously known as latent tuberculous infection. Now, this is the algorithm which is on your tables, and you are seeing that this was a summary of all this which I have just told you. We are not repeating that. The paper is with you on the tables. The next important issue is breastfeeding. Breastfeeding is not contraindicated. Encourage breastfeeding. ATT are excreted in the breast milk, but the dose is less compared with the therapeutic dose for the infant. So there is no toxicity, and in some cases biotic pyridoxine deficiency can cause seizure. So you can add the supplemental pyridoxine in the infants who are taking INH or who are taking mother feed and mothers are taking ATT. Mother should observe the cough etiquettes, and BCG vaccination is another issue which should be instituted preferably after stopping INH prophylaxis. Next, I would touch congenital malaria very briefly. I would just go on to the pathophysiology of malaria, that how it occurs. Look, the malarial infection of placenta is affected, which is characterized by syncytial trophoblast and villus destruction. syncytial knot formation is there and fibrinite deposition would be there. When there is syncytial destruction, this result in the subsequent clinical feature in the babies like low birth weight and other congenital infection feature. Now remember that malarial infection can cause two extremes. Since there is transmission of the malarial parasite, but concomitantly the transmission of immunoglobulin or IgG levels as well. So IgG level can be protective against malaria in infants and against the severe disease via acquired maternal immunity. Or on the other hand, this is the interplay between the immunity and the parasitemia. If the parasitemia is more, they can result in all the features which you can expect in the cases of congenital malaria. If we have understood this pathophysiology, then the symptom usually appear when the half-life of maternal IgG antibody is lower down. This is coinciding with the half-life, and usually it appears, onset of symptoms on average appear between 3 to 12 weeks after birth, but usually literature has reported as early as first week of life. One thing we should remember that we should differentiate again with the epidemiological history, the congenital infection and acquired infection. Past history and relevant history of the mother is very much important to differentiate it from the vector-borne malaria, because in the cases of congenital malaria, this cycle has deficiency of exoerythrocytic cycle, and since this is deficient in exoerythrocytic cycle, we are not in need of giving the radical treatment therapy of primaquine, etc. This is a list of symptoms we can expect in cases of malaria, and if we have the diagnosis, we can diagnose the cases as on the CBC, on peripheral film, thick and thin film, rapid diagnostic tests which are available, serology based, and ancillary investigations are there, which is CBC. We can check the hemoglobin, and we can check the reticulocyte counts as well. We can treat the cases of malaria as we treat the cases of malaria beyond the neonatal period, which is chloroquine or chloroquine resistance area and combination therapy. And in the falciform severe cases of malaria, we can give the combination therapy alongside of supportive therapy. We can give the blood children site with distros and the chloroquine, and primaquine usually not given in the congenital malaria, as we discussed that there is no exoerythrocytic stage of the parasite. Primaquine is also contraindicated in pregnancy and lactation, so remember that there is no radical treatment strategy for pregnant women like primaquine would not be given. And we can use the artesunate-based therapy in kids as well, and obviously supportive therapy and use of preventive measures. So in summary, when we suspect the neonatal infection, sepsis, or unexplained fever in infants presenting with hemolytic anemia, jaundice, and hepatosplenomegaly in malaria endemic zones particularly, we should keep in mind the differential diagnosis of congenital malaria. And in those cases of septicemia where we have epidemiological link and high index of suspicion of tuberculosis, and sick infant fails to improve with antibiotics and has negative microbial results for infections, we should think of congenital tuberculosis. So thank you very much.
Assalamu alaikum. I'm Dr. Salman Javed, working as Associate Professor of Neurology at Children's Hospital, Faisalabad. So this is our final presentation. It would be a scenario-based interactive session to make sure that you remain awake by the end of it. And I would encourage if the PG trainees or fellows participate. So our first scenario goes like, a 36 years old female is just gave birth to a male infant. Upon physical examination of the neonate, it is noted that he has multiple maculopapular nodules spreading all over his body. Furthermore, absence of red reflex is noted. Palpation of the abdomen reveals swelling in the left upper quadrant, and auscultation of the heart reveals a medium-pitched continuous murmur in the pulmonic region. So, what is the rash? Right, it's blueberry muffin rash, which is due to subdermal erythropoiesis. And most likely diagnosis is congenital rubella. It is suggested by the blueberry muffin rash, which is a maculopapular rash in the form of nodules spreading all over the body, which do not blanch under pressure. Similarly, there was absence of red reflex, which is due to cataracts and splenomegaly and patent ductus arteriosus. So what is the differential diagnosis of this rash? Can you see this rash in other conditions as well? Okay. Sorry? So you can see it metastatic neuroblastoma or congenital cytomegalovirus infection. And what is the mode of transmission of congenital rubella? Would anybody like to respond? So good. Humans are the only source of infection when it comes to rubella. Transmission is through direct or droplet contact from the nasopharyngeal secretions. Once inhaled, the virus replicates in the respiratory mucosa and cervical lymph nodes before reaching the target organs via systemic circulation. As a result, a pregnant mother can transmit rubella to the fetus. Now we move to our second scenario. It's a big long one. A 2-week-old male born to a 30-year-old gravida 2 mother at 38 weeks of gestation through spontaneous vaginal delivery. The mother had poor prenatal care due to social and economic reasons. Apgar score was good. The infant was formula fed. He had poor appetite and was not thriving. On examination, his weight was 2.8 kg, which was at 3rd percentile, and length and head circumference were 1 centimeter below 3rd percentile. The vital signs were stable. Infant was pale and irritable. There was no dysmorphic features. He had normal muscle tone and no focal neurological deficits. Movements of the extremities were normal, and he has nasal congestion. Skin examination revealed diffuse erythematous palmoplantar keratoderma with desquamation and fissures on his hands and feet, especially over the palms and soles. Multiple linear scaly fissures were noted at the angle of mouth. The abdomen was slightly distended, with the liver 2 centimeters below the costal margin, and spleen was just palpable. There was no lymphadenopathy, and the ophthalmological examination was normal. Rest of the examination was unremarkable. So what is the most likely diagnosis? I would take a pause due to azan. I think azan. Azan ke zara pause karna. जी ये क्या है? So it's congenital syphilis. What other signs would you look for? So the baby, the baby can be premature, small for gestational age, or having non-immune eye drops. There can be involvement of reticuloendothelial system in the form of generalized lymphadenopathy or hepatosplenomegaly. There can be involvement of CNS with the signs of acute meningitis like bulging fontanelle and vomiting, pseudoparalysis, They can be untreated, untreated neurosyphilis may lead to meningovascular syphilis with hydrocephalus, cerebral infarctions, and cranial palsies. And there can be salt and pepper chorioretinitis, glaucoma, and uveitis. Involvement of the mucocutaneous system can lead to snuffles, which is thick or bloody nasal discharge. A maculopapular skin rash followed by desquamation, blistering, and crusting is prominent on palms and soles. And there can be condyloma which can be perianal or perioral areas of hyperpigmented skin in the form of nodules, which are usually painless. So can you recall the radiological signs taught earlier? So they can be symmetric long bone lesions that are more common in the lower than in the upper extremities. Metaphyseal osteochondritis with mild to destructive lesions that develop within 5 weeks of infection. Wimberger's sign, which is demyelinization and destruction of the proximal tibial metaphysis. Diaphyseal periostitis with periosteal newborn formation. And osteitis with alternating bands of translucency and radiodensity. Now, if you look at the X-ray, what is the finding? If you look in circle, you can see the periosteal elevation, which is due to periostitis. There is newborn formation due to irritation of the periosteum. Similarly, if you look at this X-ray and look at this area, there is the periosteal newborn formation, which is giving a line over the bone. And now if you look at this area, at the proximal tibia and distal femur, there are metaphyseal bands. Now can anybody guess it? What is the finding in the X-ray? These are metaphyseal bands and periosteal newborn formation. And this X-ray is showing osteochondritis. Basically, this is the involvement of the bone underlying the cartilage. When the bone undergoes necrosis, the dead pieces of the bones hang freely within the periosteum. It's quite a painful condition, and basically it leads to the pseudoparalysis. The neurological system is otherwise normal, but the baby comes to you with inability to move the arm or leg, and the cause is the involvement of the osteochondrium or periostitis. So what is the Wimberger sign? It's a destruction of the medial metaphysis of the tibia. You can look here. Lab findings, there can be anemia, leukopenia or leukocytosis, or thrombocytopenia. IgM antibody is positive. VDRL test should be more than 4-fold greater than the maternal titer. And trypanosoma pallidum particle agglutination test is also 4-fold greater than that of mother. CSF fluid abnormalities like pleocytosis, elevated proteins, and low glucose, and VDRL test of the CSF is positive. It's worth mentioning there is no test which at birth will identify the asymptomatic with normal long bone examination as definitely infected or uninfected. So most infected babies will be asymptomatic at birth. Review of the maternal serology and follow-up the infant will over time indicate whether infection has occurred. In most cases, the diagnosis is presumptive and based on serological and clinical features. If we look at the CDC definition of confirmed, proven, or highly probable congenital syphilis, there should be an abnormal physical examination that is congenital syphilis, and a serum quantitative non-trypanormal serological titer which is 4-fold greater than the mother's titer at delivery. For example, if maternal titer is equal to 1:2, the neonatal titer should be more than 1:8. And a positive dark field test or PCR of placenta, cord lesions, or body fluids, or a positive silver stain of the placenta or cord. So what workup would you advise? Should be complete blood count, long bone radiographs, CSF analysis for VDRL, cell count, and protein, and other tests as clinically indicated like chest X-ray, liver function test, neurological imaging, and auditory brainstem reflexes. What is the treatment? Now it's the easier part. What is the treatment of syphilis, congenital syphilis? Sorry? Even you can give benzyl penicillin, which is at a dose of 30 mg per kg IV, 12 hourly for 7 days, and then 8 hourly for the next 3 days. And every baby who turns positive to syphilis must be screened for congenital AIDS as well, both the mother and the baby. And if IgM test is negative, other tests are reactive with the titers of less than 4-fold than higher than mother, with no signs of congenital syphilis, and you have to repeat reactive tests at 3, 6, and 12 months, or until all the tests are negative. Then we will label that the patient is syphilis-free now. He has been treated. So our last scenario, a male newborn delivered at 37 weeks of life by normal vaginal delivery. Birth weight was 2.6 kg. The Apgar scores were good, and his mother had no history of genital herpes simplex during pregnancy or at the time of delivery. Pregnancy was uneventful, and general physical examination of the baby was unremarkable. On third day of life, mother noted the appearance of a red spot over the neck, which rapidly extended to the face, anterior thorax, and right arm. On fifth day of life, the crops of the vesicles developed on the erythematous areas, resulting in ulcerations and crus. Now, this was a rash that was gradually progressing. Now, what is the most likely diagnosis? No, it's neonatal herpes simplex virus infection. If we look at the rash, we have a differential diagnosis. Can you identify what kind of rash is it? The next one. Okay. This is the commonest rash observed in newborns with erythemas and few macular areas with pustules that appears on third day of life. It's erythema toxicum. Can you identify this kind of rash and differentiate from this one? Any clinical fellow or trainee? So these are fine pustules with areas of depigmentation. It's benign neonatal pustular melanosis. And this one, commonly seen nowadays, these areas, erythematous areas with overlying papules and few vesicles. Would anybody guess? Very common nowadays. Miliaria rubra or heat rash. So most of the affected newborns acquired the infection from maternal genital tract during delivery. However, 68 to 80% of the mothers have no medical history of contact with partner with genital herpes simplex or signs or symptoms of genital herpes during delivery. And infection by genital herpes is normally caused by herpes simplex 2. However, the clinical picture and treatment plan is similar for herpes simplex, whether it's virus is simplex 1 or 2. Because you don't need to differentiate, although the disease is a bit aggressive in type 2 infection. Time of presentation is important. Newborns that acquire the virus during normal delivery generally present symptoms 6 days to 3 weeks after birth. Although in some cases, like this one, the lesions can already be observed on first day. As far as the types are concerned, there are 3 types of herpes simplex virus infection. What are the 3 types? I think nobody wants to respond. Okay, the first one is the disease limited to skin, eyes, or mouth, which is seen in 55% of the cases. There can be localized central nervous system disease with or without skin involvement, seen in 35% cases. It presents just like meningitis, with fever, vesicular rash, and abnormal CSF findings. And the third one is the disseminated disease, just like DIC, with involvement of multiple organs, most prominently liver and lungs. It presents with sepsis, negative bacterial cultures, and severe liver dysfunction or DIC within first 30 days of life. Regarding workup, you have to go for CBC and CRP like any sepsis, blood culture, liver function tests, whole blood sample for herpes simplex virus PCR assay, Zank smears, swab specimens from the mouth, nasopharynx, conjunctiva, or anus for culture and PCR, specimen of skin vesicle for herpes simplex culture and PCR assay, and CSF sample for herpes simplex virus PCR assay. An eye examination and neuroimaging, in which MRI is better than CT scan to establish baseline brain anatomy. What is the treatment? Acyclovir, good. Parenteral acyclovir is a treatment of choice. Dose of acyclovir is 20 mg per kg per dose, 8 hourly. given IV for 14 days in skin, eye, and mouth disease, and a minimum for 21 days in CNS or disseminated disease. In case of CNS disease, you have to repeat the CSF DNA PCR after 21 days of treatment. And if it's positive, you have to extend the treatment for 1 week further and then again do the DNA PCR. Infants with ocular involvement would receive topical drug like trifluridine, iododeoxyuridine, or gencyclovir, as well as parenteral antiviral therapy. An ophthalmologist should be involved in the management and treatment of acute neonatal ocular herpes simplex disease. What else would you do besides the cyclovir? Infants surviving neonatal herpes simplex infection of any kind, whether it be skin, eye, mouth, or disseminated or skin disease, should receive an oral acyclovir suppression at a dose of 300 milligram per meter square per dose, administered 3 times daily for 6 months. Absolute neutrophil count should be assessed at monthly interval during this treatment period. Novitis suppression is mandatory. Though there is no mortality associated with skin, eye, mouth disease, about 30 to 40% babies would develop neurological impairment if they do not receive antiviral therapy, and they may present with spastic quadriplegia, microcephaly, or blindness up 6 to 12 months later. Similarly, an infant may appear healthy and some may have subclinical infection of CNS, and moreover 75% of the babies with skin, eye, mouth infection progress to either CNS involvement or DIC or disseminated disease in the absence of antiviral therapy. So this is probably due to the widespread viremia leading to involvement of brain, liver, lungs. Hence, all the infants with skin, eye, mouth disease should be treated aggressively and followed carefully up to a period of 6 to 12 months. Thank you.
Thank you, our all facilitators. Now, I would like to invite our chief guest, Professor Ashraf Sultan Sahab, to come on the stage and share his valuable comments about our breakout session. Sir, kindly come on the stage.
Well, let me first thank organizers for inviting me to this Congress. Incidentally, this is the first time that I have been invited to such an event, and it's perhaps the first time that I am spending so much time with the neonatologists. It's said about the pediatricians that pediatricians are physicians who never grow. They remain pediatric physicians. So what do I say about neonatologists? So how would you define neonatologists? So I'll leave it to you. The subject was very important, congenital intrauterine infections, but somehow we don't hear much about that, and we don't report many such cases, although they definitely are there. So why is it? The first of the reasons could be that we are missing such cases. Even if we are diagnosing, we are not reporting those. So people don't know that there are so many cases of congenital infections around. Or actually there are few cases, less cases of congenital infection as compared to those who are being reported in international literature. I gave example of COVID. So COVID has been devastating, causing mortalities. India shares most of the epidemiological features of infectious disease with us. But in India, they were short of space to bury their people. But somehow Pakistani people survived that onslaught, and we did not have those waves of COVID infection as we have seen around Europe and many other developed countries. Perhaps this brings up a point that our kids are so unprotected that they get every damn thing during their childhood. The infection like rubellas, if you have natural infection, you could lose immunity subsequently, but immunity is longer compared to immunization. If you are immunized, may lose immunity after 5-6 years. But if you have natural infection, it would take 10-20 years before you lose immunity. And secondly, many infections, if they are primary infection, would infect the newborn. If they have had infection before, during childhood, so they are also protected. Relatively less risk of transmission of disease. So perhaps that's an explanation that we are not diagnosing, we are missing few, we are not reporting them, but actually there are less number of congenital infections in our part of the world for reasons the moms would develop immunity because of prior infections in their early childhood. So that could be one of the reasons. When I was under training, my consultant once said that if you find a case of duodenal atresia, look back at the face again. You might have missed Down syndrome. So that stands true for congenital intrauterine infections as well. If you have a patient who has a syndrome, so that would mean there was an early infection and there were multiple physical findings which you should find around. But if it's a late infection, then you would have isolated finding. Some of those may have thrombocytopenia alone, some would have sensorineural deficit, some would have glaucoma, for example. So you could miss the second part of it, the isolated finding, but the syndrome complex should not be missed. And I think the basic parameter to suspect a syndrome is that if you are dealing with a baby who has had intrauterine growth retardation, that's the basic parameter. So because there would be none who would not have it. So all those who have had the intrauterine growth retardation should be looked at with suspicion. Okay? So that's the basic parameter. And if you find hydrocephalus with that, the only diagnosis is toxoplasmosis, because nothing else causes hydrocephalus. Okay? And along with intrauterine growth retardation, if you find congenital heart disease, that's rubella syndrome, nothing else. Okay? Similarly, if you find intracranial calcification, the distribution would tell you whether it's cyto or toxoplasmosis. So make things simple. Have an index of suspicion if there is intrauterine growth retardation. And then once you have an high index of suspicion, then you would not miss it. Then because you will look at it. If you find a rash, blueberry muffins are diagnostic of rubella and cytomegalo, for example. So keep things simple, but have a high index of suspicion. Congenital malaria, congenital tuberculosis, Pakistan is at the top of the list of those population which has tuberculosis. We are one of the 5 which has most number of cases of tuberculosis. Are many areas in Pakistan are endemic for malaria. Some are hyper-endemic for malaria. But even then, we don't have many congenital malaria reports. First, again, we are missing out. Second, most important is that if a naive individual gets malaria and is on family way, her kid would definitely have malaria. So the congenital malaria would be there. But a mom living in hyper-endemic area, because of repeated infection, we develop so much of immunity that along with the malarial parasite, she would pass on the immunity as well to the newborn baby, antibodies as well. So the malaria would be less likely, or would not be so florid, or there would be late presentation of this congenital infection. So that again is true about tuberculosis, I suppose. This is blessing in disguise, that so many infections in the mother that she passes on large number of those to the baby, and the baby is protected. Thank you very much again for the invitation, and thank you for the speakers for the doing hard work to prepare, and I appreciate आपके सब्र का भी शुक्रिया अदा कर देते हैं कि आपने बहुत सब्र किया है. Thank you very much जी. अल्लाह हाफ़िज़.
Sir, please stay on the stage for souvenir distribution. I would like to invite first for Professor Fahim Afzal. आ जाओ. दो ना. आ जाओ. Sir, souvenir distribution. Professor Farah Haroon. Dr. Salman Javed. Dr. Rizwana Tariq. Dr. Aisha Siddiq. Dr. Aisha Siddiq is also to receive souvenir for Dr. Zahid. Unfortunately, he is not with us today. He is not here. Dr. Zahid is not here today.
अच्छा.
She will receive her souvenir.
Souvenir दे.
हाँ जी.
उन्होंने किया क्या? अच्छा, presentation. Okay.
And staff nurse Asia Siddiq. Lastly, I would like to invite Dr. Farah for souvenir distribution to Dr. Arshad Sultan.
Thank you very much. Thank you.
Thank you. Thank you all delegates for joining us in this educational journey. Good afternoon.
Yeah. आपने दिया है तो मैं गाड़ी तक तो लेके जाऊंगा. कोई बात नहीं. बहुत अच्छी नहीं है लेकिन इस काबिल है.